So hello and welcome everyone to our panel session. We are titled The State of Play in Digital Transformation. So quite a broad subject, but hopefully we'll set the context in the next few minutes. Firstly, thank you for selecting our session over the other offerings. We're hoping in sort of half hour, 40 minutes, you'll realise it was the top choice to make. And we want to have your participation, so get thinking of any questions that you want to grill our panel about. I'll start with some introductions, set the scene a bit, and then we'll move into, as I say, grilling our wonderful panel about their experiences and thoughts on how we can drive forward digital maturity. So to start with myself, my name's Sarah Thompson. I'm a pharmacist by clinical trade, currently a CCIO at Wirral University Teaching Hospitals. Moved there about 6 months ago from many years working at Stockport, a little bit more local, but we're just down the road still at Wirral. I'll move on to the panel to introduce themselves.
Yeah, hi, I'm Andy Webster. I've come across the Pennines today coming from Leeds. I'm an emergency medicine by training. My colleagues describe me as generally optimistic in nature. Also one of the Chief Clinical Information Officers, and some of my other colleagues are in the audience as well, so welcome.
Thanks, Andy. Good morning, everybody. I'm Eddie Oller. I'm the Chief Digital Officer for Coventry and Warwickshire ICB, one day in. Before that, I was the Regional Director for Digital Transformation in the Midlands.
Hi, everybody. Rod Joyce, Deputy Director of Innovation in the Transformation Director in NHS England.
Hello, everyone. Will Goodwin, Assistant Director of Programmes in NHS England, doing digital maturity and capability within frontline digitisation.
Thank you, and thank you to the panel for agreeing to be here to give their on-the-ground experience. So the discussion topic that we've been set today is around the state of play in digital health, and I guess it couldn't be more of a political hot potato at the minute, given the recent Select Committee expert panel report that rated the government's approach to digital transformation in the NHS as inadequate. So really summarising that, it summarised that the overall progress on improving digital capabilities in the NHS was found to be too slow, often lacked support and funding. And interestingly, experts also detailed that social care was often missed out, which affects our integrated care models. I'm sure you'll see a lot of the focus of today's event is around how we tackle these problems of scaling, accelerating digital transformation, and meeting some of the new digital maturity standards, particularly in a time of funding deficits. And this comes at a time, really, where there's a lot of change, a lot of moving landscapes in digital healthcare. Some funding's available, there's still uncertainties around that. National changes have been seen in the recent move from NHS Digital to the NHS England Transformation Directive. Good luck getting your tongue around that, as you keep saying it. Alongside discussions around digital maturity assessments, what good looks like. And I guess in trying to outline this session, we realised that the subject matter is huge, and we wanted to really focus in and narrow down on what's shifted recently and what this actually means to organisations. And in particular, we want to explore the relationship between national and local. So some of the discussions are going to be around standards, assurance, and yeah, that's just setting the scene, I guess. So let's open up the conversation with our panel. Andy, I'm going to start with you. So as a frontline clinician who also has a digital role, off the back of the Select Committee report and its findings, what reflections or challenges are you feeling?
I don't know about the rest of you, but you may all be working in utopian areas of digital technology, but in Leeds, I think it quite resonates with the findings of the Select Committee report, is that actually we've got some really good beacons of practice in Leeds. So we've got a really mature shared care record, which has been in existence for at least 8 to 10 years. And that's been really powerful as a clinician, getting access to information on the shop floor 24/7. When I was the first emergency medicine consultant in Leeds, you had to get the facts from the GP, and once they were closed, you had no information to patients. There's quite a lot of transformations that happened, and that's the good beacons, but there's so much we need to require improvement. Just getting the foundations right. We're still running quite a big Windows 7 estate in Leeds. We've also got... We'll probably delete that bit, shall we? We've also got quite problems with other foundations, the telephony system, networks, all need improving, so that's kind of rated inadequate. But actually, as an optimist, I can see that we've got a great strategy moving forward, if only we can secure the funding moving forward and and get things right in place. So the potential is there. We've got a really enthusiastic workforce. Again, as highlighted by the Select Committee, we haven't got enough of the people, and it's a challenge both getting the training right and also just getting people. In Leeds, we've got an issue with a really mature digital kind of system, but we've got people who'd rather go work for Sky Bet at twice the kind of the cost. So we've got a real problem recruiting the right members of staff. I don't know what others feel.
It's a picture we see across the country, you know, and there's some pockets of excellence and there's some pockets where that really need that support. So I think we see that reflected right across the country.
Brilliant, thank you. I think there's some interesting reflections there and some points we'll pick up later. Moving on, Eddie, considering this in your role from the ICB perspective, how do we think about digital transformation in the ICBs? How can we potentially leverage them to move forward change? What are some of the challenges you're facing at the ICB level?
Yeah, thank you. It's a great question because I bring a wealth of experience of one day as a CIO in this post. So please listen up to some really great insights. But no, on a more serious note, I think in my regional director role, working for NHS England, one of the things that we saw again and again is this kind of inequity in digital maturity across, not just across acute providers, but also within systems and then also across the country and the region. And there's something to me that one of my interview answers was about, there's something about taking stock and being systematic about the way we try to do things. We can't do everything at once. So it's clearly, I like the framework that NHS England, I'm slightly biased, we'll put it out there, the framework which is to digitise, connect and transform. So we always start at the end of transform, don't you? What can we digitally transform and what programs to do? But actually to do that, we've got to have a context of what it is we're transforming to start with. So we've got to digitise some of the things. So if there are any clinicians in the room, just show of hands. Yeah, okay, so clinicians in the rooms, when you go out and you see patients, how often are you still using paper? You know, and that tells you something, that part of that workflow is broken. If you're going to transform it, we need to understand what's not digitised and what we need to digitise. I think when you look at the ICB's role in the Connect domain, then it's about trying to work with ICSs and the makeup of ICS, and that includes health and care providers and the voluntary sector, to ensure that there's an opportunity to make sure we get this complete record and complete picture of the patients, the citizens, the people of what the ICS serve. And what I mean by this is building on some of the digital maturity discussions that you'll hear about shortly. It allows us to think of a coordinated, funded strategy that moves bringing together, and you've heard the word convergence before, but it's not in convergence in the context of technology. It's convergence in the context of the patient pathway, the workflow, the care pathway, the journey, in which we then start to make sure these are priorities that we need to digitise before we connect up the solution. So we really just need to spend a lot of time and effort on understanding the landscape and then having a clear programme of activities that takes us there. The tech will come along, and we've talked about really great innovations that are out there that are coming. And I think we can then use those innovations to transform further what the pathway experience will be for the staff, and that's an important thing, as well as those on the case users, for example, the patients, or in this case, could also be the population from a preventative health perspective. So we start intervening early. So while population health management is an important tool to use in that, again, it needs to be clinically led, digitally enabled. We need to then ensure that we're really thinking about what problem we're trying to solve and bring the challenges together and align them with the solutions that are going forward. So those are just some of the things that I'm going to do tomorrow. And then if you invite me back the day after, I'll evaluate that and give you some things. But
Thank you, Eddie, for that. You know, I'm glad to hear your first 24 hours has brought such wisdom. So moving on, looking from the ICB level onto a more national level, and posing the next question to Rod, considering the relationship between national and local, how can we support one another meaningfully? So how do we get the basics right now around standards, assurance of quality? What's your thoughts on that?
it's a huge challenge, but I think one that we have to tackle. And when you listen to Eddie and Eddie's sort of colleagues around the maturity that they're looking to develop at sort of ICB level, that also does vary across the 42. So it's really hard for us to be able to look at, okay, what do we need to put in place and the structures we need. But when you were talking about digital equity and maturity, there is also responsibility on the suppliers to meet that as well. And I think what we can do is nationally is to say, set out what those requirements are for suppliers looking to enter or maintain capability within the market. And through looking at the standards and assurance, it's the first of many, many work streams that we have across that, where things like DTAC and the DTAC survey have been critical in identifying what are the baseline standards required and what are the standards required to enter the market. These are standards typically that happen through BSI or various other things in other industries. How do we make sure that we have that commonality, we have that low bar to start with, and slowly then we can start to build that bar? And the audit was there to be able to say, what is the state of the nation? So to try and answer this question, we don't know what maturity of digital tech, what safety looks like, what anything around the baseline standards are across the country. And people are, we know that there's resources being wasted by continually doing these assessments. So passing some of that responsibility to suppliers to say, we are safe to enter the market, we are safe to continue operating in the market. There is loads more we need to do. We need to work with colleagues to be able to say, what do you want us to do next? And how do we use the data? But the important part for me was to generate that data and that evidence to be able to say, this is the state of the nation. What do we do with the knowledge that we now have, and how do we support local, make better buying decisions? So that's kind of a really, really key point, because we then get, I think, the justification to be able to move into early stage impact, into efficacy, clinical efficacy, sharing best practice, sharing knowledge. I think we can't get to those points until we get the baselines right.
Yeah, and I think I can absolutely see the benefit of the data, the use of DTAC, but as an individual representing a relatively digitally mature organisation, it was really a huge burden on us to gather that data starting from scratch. And it's good to know that data is going to be used, but we need to see the output from that. And
absolutely, and I'm looking at the team who are responsible for doing it, and it's there to support people make better decisions, look at the risk they're carrying, look at digital safeguarding as a whole holistically, to be able to say, okay, it's not there to beat you over the head and say you're doing the wrong things. It's there to encourage you to say, this is what assurance needs to look like. And we can then move forward collectively saying that we're using the right technologies for the right reasons with the right patient outcomes. Then we get the opportunity to say, okay, where do we go next?
Brilliant, thank you. Please just don't let it be one of those things that we've given you all this data
no,
and then there's something else that comes along. We want to see the outputs from that. Some really interesting food for thought there. And I guess while we look forward to the future, you've touched upon it slightly in your answer there, Rod. We need to consider the legacy systems and their arrangements, and quite often that's the hardest area to assess. The new come into the market, we've got DTAC, we've got these standards. How do we work as legacy systems in making sure that they come along with us? So I wonder, Will, if you could help us with bringing in some of what good looks like with regards to this. So moving to the frontline impact, how do we consider what good looks like and driving forward change, incorporating feedback from the many thousands of systems we've already got in use?
Yeah, I think just to sort of pick up on that, how do we bring those legacy systems on that journey? I think we just need to look at something like the Frontline Digitisation Programme, where we're investing 1.9 billion into EPRs, and that's not just about upgrading existing very mature EPRs, it's about how we bring everyone else on that EPR journey, so people who haven't got EPRs and also people who have got EPRs that need to be optimised. So we're investing across the whole sort of range. We want to level everyone up as part of that agenda to bring up the sort of that tech disparity with the older systems with the new systems. But sort of what good looks like acts as that, on the back of that, acts as that North Star. We realised quite during the pandemic that there was lots of people talking about tech in lots of different ways, but we didn't really have a defined way of, thinking about it and what we should be aiming for and what aspirations we should have. And that's where What Good Looks Like came out and was born from. We wanted to create that sort of digital North Star that people can sort of focus on, aim on, and it can be really understandable and relatable. And one of the things we did as part of that was really work with the front line. We engaged with stakeholders across the entire country, from national down to front line, to rebuild on what it actually means for people. And you can see that within the framework itself, how it's developed. You know, we released What Good Looks Like for Nursing last year, which was a reflection on what does the main framework mean for nursing. And there's other professions that are also looking at it from that angle. And then off the back of that, we've launched this year the Digital Maturity Assessment. And the aim of that is to help people understand where they are on that journey to the North Star, so they can see the opportunities, they can see the capabilities they have, they can build on them capabilities, or understand where they need to gain capability to increase their maturity or attain the goals that they want to do. And then off the back of that, we can start to invest better at both a local and a national level, and gives us already that key insights we need to understand what is actually going on there, and help ICSs that are forming bring together everything and understand the landscape and rebuild on the sort of good work that's already going on.
Brilliant. So we've mentioned there around the suppliers. So how do we use that and I guess translate that information from the digital maturity assessments back to suppliers to drive forward that innovation and maturity with them? Because a lot of the time we are very dependent on bringing our suppliers with us.
Yeah, and that's, I suppose, a good example of that is where we link in with the framework we've created within the Frontline Digitisation Programme on the sort of capabilities within an EPR. And what we're doing as part of that is we're working with the supplier market to bring them on that journey. So we're trying to give the tools to the providers to know what they should be having within their EPRs, whether that's just what they need as a basic level, a sort of foundational, or what they can then attain as a transformational and innovational side as well. And with that work with the suppliers we're doing around that, we're hoping to drive that conversation and put, as Rod was saying, a bit more responsibility on the suppliers to be meeting these standards on doing them. We know a lot of suppliers in the EPR market, for example, have taken the framework we've been doing and met it to do as part of their procurements, which again we're also helping within FD, where we've got the procurement function and the support elements around it.
Brilliant. Eddie?
Yeah, I just wanted to come in and kind of emphasise that point about the benefits of what you both just talked about. So as we engage with suppliers, we now have a mature language that both the provider who wants to upgrade the system and the supplier understands. And it's really it's helping to get traction in that differentiation between innovation. So the DMA assessment, well, it's very time-consuming to fill in, and very, in some respects, it's more beneficial to us in the ICB now to be able to have that dialogue with the ICS and with providers, and then redirect the investment in the most appropriate need that needs to be done. And everybody can see that in an open and transparent way. So I think the DMA and the DTAC are really great tools that, for us to be able to increase our digital maturity in a uniformed way. So, you know, I'm bought into it. I think it's a great piece of tool.
I think at the same time as us, in the centre, saying this is the responsibility of what local needs to do, we also need to look at ourselves and understand that we have too many programs doing similar things. And we are now working a lot closer. There's the cyber assurance program, there's the clinical safety program. We need to bring that together and create the clarity that this is the requirement, the baseline. If you're looking at this sort of technology, these are the requirements. If you're looking all the way through to EPR, if you're an EPR and you can't do DTAC, then we have a much bigger problem. Yeah. So there is a baseline requirement for everything, but for each of the different types of technologies we need to look at, there are different requirements. And I think we need to work closer as a centre to be really clear on the guidance, bring those programs together to say, this is what assurance looks like. And then we get to move on to the next bit, which is the scaling bit, the fun bit, but we have to start with the baseline.
I guess the other bit I wanted to pick up on is we mentioned at the start that this select committee report picked up around the lack of involvement of social care in all of this. Where does that fit? We're speaking very much from a health system perspective, but we haven't mentioned social care.
So I could come in on that. So that's really interesting, that, because one of the first things we realised with the What Good Looks Like framework, and bear in mind, just for a bit of background, it was before the ICSs were forming. We knew they were coming into being. So at the time, it was very much sort of NHS focused, the What Good Looks Like framework on what that North Star looked like for the NHS. But with the ICBs and S's coming into sort of fruition, that whole health and care sort of system became more and more of a priority. And so this year, for example, the framework is actually expanding into adult social care to sort of create that that complete link. And it's the same with the digital maturity assessment. So we're going to be looking at how we look at the other areas of care within the system to help to bring it for an ICS level, help understand, you know, their entire health and care system rather than just say the NHS bit.
Brilliant. And I guess a final question from me, so please get ready with any questions that you may have, is back to you, Andy. You know, as somebody who is similar to myself, doing a joint role of some clinical practice and digital work, how do you translate this back to your colleagues? How do you know, manage their appetite and enthusiasm for change while knowing what's going on in the background and the challenges that you face?
I think the hardest thing we've got really kind of is managing expectations. That's the hardest thing, because we've got really enthused clinicians who come to us with their latest idea, or they've been talking to a supplier at a conference and they've got an idea they want to implement. We're still trying to get the foundations right, so it's really hard to support. We've got something like 80 projects in train in our trust. And we are quite a large trust, tertiary centre, but even for that, the amount of project managers we need to have, and we've got kind of choke points in different parts. So tech services is a real difficult area to recruit to. It's difficult to deliver those projects. And we've also got the technical debt. As part of our Windows upgrade project, we've looked at our estate, our ecosystem. We've got over 1,200 applications we manage. I mean, some of those are quite small, but just managing those and keeping those upgraded is a real challenge. And one of the efforts we're doing is trying to reduce the number of applications, but it's a real challenge. And we've got other people often presenting the same solution as well, or just from a different supplier, kind of managing that discussion, because they might have already done a pilot without us knowing. And then going back, you can't do that because you haven't actually got the right clearance for it, and where's your funding to continue it into the long term? So yeah, it's a real challenge on a daily basis, and that's one of the jobs of the CCO is trying to manage expectations, but also signpost people as well.
Yeah. Brilliant.
Can I just add, I think that's one of the big challenges of digital.
Yeah.
You know, suppliers have, you know, really good ideas and really good products, but they invariably are in silos. So this is the bit we do really well, and then you try and piece them together, and that's your job to try and piece them together. And your job's to make the data flow and make sure that, so how we get partners, how we get suppliers to think a bit more about who they work with and how their systems work and come to you with solutions as opposed to products, I think is really, really important, because, you know, otherwise you know, hundreds of people are knocking on your door saying, well, we've got the best solution for this. But we don't care then what happens downstream or upstream, you just need to plug us in because we give this. So how we create that environment and an ecosystem for partners to work together and come with much broader solutions, I think is really important to success.
Brilliant. So I'm happy to open up to any questions. We've got a roaming mic. We've got a question in the centre here.
Hello. My question is about where you sit on the buy versus build spectrum. We've got two different two ends of the spectrum here. So we've got, for example, in Leeds, PPM Plus and the Leeds Care Record, primarily built in-house by Leeds Teaching, and where we're all sitting in Manchester, where MFT have just finished their migration to Epic, a massive integrated EPR bought as a whole from a American supplier, both implemented with the help of Answer Digital, I should say. Do you think, in terms of integration, and integration particularly with social care and as an ICB, we get a better integration through a kind of more home-built or self-built solution, or do you think it's better to have a kind of more integrated solution from a kind of clinical perspective and tighter integrated workflows?
Shall I go first?
Happy for you to take that one, Andy.
So from my perspective being Leeds, we've ended up with a bespoke EPR, probably historically, because we started off with the cancer system about 20 years ago. And over time, we've never had the money to go off and buy an off-the-shelf product. And we made the decision to start building PPM Plus, our web application EPR, about 8 years ago. And we've invested a lot of money into it, and it's quite a strong product now. Now, it doesn't do everything that other EPRs do, but it works well for our people, and we can also innovate quite well. So good experience was during COVID times, within about 3 or 4 weeks, we managed to digitize our whole emergency department to electronic notes and saving 1 million sheets of paper being scanned in. We might not have been able to do that if we'd not had that ability, and we were doing things like uploading all our COVID results straight to alert clinicians when they were positive. So we were able to iteratively and quite rapidly make changes. Now, if I was shown Epic or Cerner or all these other ones, I'm sure there's features in those products which are really mature and do more things than PPM does. But at what cost? If we were to change 20 years of what Leeds have done now and have that massive business change to an Epic, you're looking at 80 to 100 million pounds minimum, I would suggest. I don't know the exact fees, probably more. What could we do if we invest that 80 million pounds in PPM and all the Leeds Care Record and Yorkshire Number Care Record? We've already got quite a mature product, but with more money we could do an even better job. But we're connecting up third sector organisations, we're connecting up social care. So we've actually got quite a mature shared care record. Not doing everything yet, but we're making great progress. We're sharing the data between clinicians.
Eddie?
Yes, it's a great question. So if you'd asked me this question on Monday, you'd have got a different answer to what you're about to get now. So I think it's ECC. So the E stands for expertise, the C first C is capability, in other words, capacity. So if you can build your own and make it local, then I can't see any supplier being able to outbeat that if you've got the expertise, the capability, capacity to do that. I think there's a relevance to local, place-based neighbourhood technology working for the people, created by the people. So I think there's a benefit to that. On the other side of that equation is we're not experts in building systems, and neither should the NHS be that. That's why suppliers do that. So in terms of the build, then you really got to be with eyes wide open, know what you're getting into, and make it a sustainable solution as we feel. So I think both sides of the equation still work, but I can see from a policy point of view there being a priority to use more systems that are proprietary than create your own.
Brilliant. Did you want to add anything?
I suppose this is where...
This is you, mate.
Thanks. I suppose this is where stuff like the work we're doing with the capability framework within frontline digitalisation, which is sort of setting out the sort of what capabilities these systems should have. So then it doesn't necessarily matter which system you have if you have the capabilities locally in the skill sets, which is quite rare, I would say, within the NHS to be able to do. You have a clear understanding of what the expectations are if you decide to go down that route. But then also, if you don't have those capabilities and you're looking to purchase a system like an enterprise EPR, for example, you actually know what you need to be getting from that, and everyone is getting the same sort of capabilities, of maybe in a different flavour or slightly different way because different suppliers do them that way, but you have fundamentally the same sort of capabilities within that system.
I would just say it's appropriateness is the right thing, and the pragmatism of that I think is really important across any sort of digital deployment. If we think it's the right thing to do and we have the right resilience and we have the right opportunity to do it, then I don't see why we don't just continue to do that.
Yeah. Andy?
To say, it is a 20-year journey we've done, so if we were doing the same thing today and starting without an EPR, we may not make the same decision. It's just happened with various decisions. And we don't build everything ourselves. We do use suppliers to supply things like our PAS system and our order request system. So, and we've got our own maternity system as well, which is done, which we kind of link together. So it's not all built in Leeds.
I think it leads on to that question of, it's a challenge I've faced in the organisations I've worked is those technical development roles, we just can't recruit and retain to them in the NHS banding structure. The private industry is just far more lucrative with regards to, reward for them. So I think if you've nailed that, Andy, we'd like the answer. Any other questions from the floor, please? Yeah, we've got one at the front here.
Thank you, panel. I'm Simon. I will soon be Eddie's neighbour, actually, as Chief Digital Officer for Herefordshire and Worcestershire ICB. I'd like to pick up on the last comment that was made, because I'm really interested in the digital skills, digital professionals. We have less than 2% of our 1.3 million workforce are DDAT people. I'm curious in the panel's reflections as to what skills you think we actually need in the NHS and sort of where they should sit. What should sit within the trust context, what should sit within ICBs, and what could and perhaps should be provided by suppliers or by national organisations?
Brilliant question.
Absolutely. What are you trying to build, Eddie?
Yeah, shall we start there? Yeah, so welcome to the patch. Looking forward to working with you. So this is an interesting question because it's also about professional development and a pipeline for our staff as well as where they sit. So I'll put that caveat out there. And what I would say is that Sarah mentioned quite rightly that there are some technical skills that we just can't afford. And we can't afford it in two senses. One, we can't afford to pay them enough because their expertise is so scarce and people want it. And the second one is we can't afford because the liability of a cybersecurity specialist making the wrong decision sits within the NHS boundaries and not necessarily in the cybersecurity domain where it should sit. So I think there's something about the right skills for the right expertise, again, that go there. But in the real world, we definitely need data people, so data scientists, data analysts, data will be key, because once we've digitized as part of the framework, we'll need to understand what that data is telling us and to be more intuitive with decision making, so we'll be able to use that data from its background context. And we need lots of change and transformation specialists, because really, once we have digitized and we've got over that hurdle, we've talked about it's the people changing the process change that's the biggest challenge, not the technology, so people will recognize that. So I'm less worried about, I don't think I have a view where they sit, but I do think there's a pipeline for us to develop that is important, and there's something about sharing that expertise across the ICSs and acute providers.
Andy, would you like to share your reflections around, I guess, the more clinical input that may be needed?
Well, I suppose it's not one size fits all. Leeds a £1.7 billion organisation, so any organisation that sell would have their own, some of that in-house, wouldn't they? So it's about, we for our PPM development, we work quite closely with a local software company who provide a lot of that kind of development and technical skills. And then we've used agencies for some of our contracting staff because we just can't recruit. And we've got a mixture of some of our own staff. And actually, some of the staff, even though they could go off into the private sector and earn twice as much, they like to support the NHS. They feel they're doing a real great change by developing the Leeds product. And then we've also got links to the universities and the innovation hubs. So it's about having that right ecosystem, isn't it? And we're looking in Leeds, we have got those university links. We've got technology partners we can work with. So, but other parts of the country aren't so lucky. They're not going to have that ecosystem they can rely on.
Brilliant, thank you. We've probably got time for one more question, if we'd like to take this one from the front. Thank you.
Richard from the FCN. I wondered if you could speak a bit about medical device certification intersecting with artificial intelligence for decisions, bears on the buy and build and the skills as well.
It's a huge question. I think there is a lot of work happening in that space, and looking at AI as standalone as opposed to AI in products, and what do we genuinely mean by AI and machine learning, and the assurance we need to put around those, the medical device classifications we need to put around those, is a really complex task. And I think there's a huge amount happening both with NHS England and across the MHRA at the moment, where they've started to look at this, but it's a long conversation to really understand the implications of clinical decision making through AI, for example, and we're starting to see some of those things come through in mental health. But and those sort of products are having to go through medical device classifications. But then the questioning of, is that the right route for them based on the type of technology they're creating and the type of output that they're then generating? So it's a huge challenge for us, but one I think we have to tackle, because these technologies that come along and in some cases replacing workforce, replacing clinical workforce, or then complementing those and creating a better environment, we need to be really cognizant of the impact that's having on patients. So it's a huge challenge for us.
Yeah. So I think that's a leading question. So I'm going to answer it in a couple of ways. So the first thing I would say, if Twitter wants to light up on this, is that AI will replace clinicians, but it replaces the clinicians that don't use AI as well. So those will be the core. So it will not replace everybody, but it will replace those that don't use AI. Because if you look at the large language modules that's coming out now, they are really able to learn quite quickly a lot of the context of which clinicians spend years learning and regurgitating. And the impact of that means that for patients, looking at the way we've used technology in the past with chatbots and telephony things, it's a game changer, because you can have a conversation with Andy as if it's Andy, because the machine and the language and the prompts that you use are giving you the right feedback, which is a safety thing. Then we're into the issue about how we can make that accredited, and we make sure where the liabilities sit for using that AI and bringing it all together. Now, there are far more cleverer people than me that are going to solve this. And I think they're going to solve it very quickly. So working in partnership with research industries, with the universities, I think this will get resolved very quickly. So there's lots more to come in that space. I think that you alluded to that.
Brilliant. I think that's probably about... Oh, we've got one waving hand here. I feel that we need to take this final question, and then that is it.
Hi, yes, so I was very interested in this build EPR for Leeds, and I was just interested if you had any other trust wanting to reuse what you've built, and how feasible would that be?
So we already have one local trust to us that called Mid Yorkshire, who currently use PPM. So we have actually scaled it across. And the good thing about PPM is that we've moved most of the elements of PPM into the cloud, into Microsoft Azure. So it is a scalable solution. We haven't worked with anybody else apart from Mid Yorkshire, but potentially it could be done.
Brilliant. Thanks, Andy. So we'll draw this session to a close now. So thank you to our fabulous panel for their insights and honesty. Not sure if we've answered more questions or created more along the way, but it's been great to involve you all. Thank you for coming, and enjoy the rest of your day. Thank you.